Good afternoon, and welcome to the Walter Allen Memorial Community Lecture. My name is Melita Terry, Community Engagement Coordinator at the University of Pittsburgh Alzheimer's Disease Research Center. This series is named in honor of Walter Allen, a prominent African-American photographer who worked for the New Pittsburgh Courier in the 1950s and 1960s and later died with dementia. The University of Pittsburgh Alzheimer's Disease Research Center has presented over the past several years the Walter Allen Memorial Community Lecture in the Historical Hill District. The series offers a platform that brings researchers and clinical experts to community settings, creating interactive and educational programs on Alzheimer's disease and other related dementias relevant to the African American community. Before we get started, I would like to share a few housekeeping items with you. This event and lecture is being recorded. If you do not agree to participate in the lecture being recorded, please disconnect and you can view this at a later time on our YouTube channel, Pitt ADRC YouTube channel. There will be a Q&A session that will follow the presentation. Please write your questions in the chat. If you are attending from a computer, at the bottom of your computer, select the chat button, type your comment or question and hit enter to share. If you are attending from a mobile device, tap the screen to make the controls bar appear, then tap on participants, and at the bottom of the list, tap chat. Type your comment or question and hit enter to share. At this time, I have the pleasure of introducing to you Dr. Robert Sweet. Dr. Robert Sweet is the core leader of the clinical core at the University of Pittsburgh ADRC. Rob?
Thanks, Melita, and thank you all for joining us today. It's really my pleasure to introduce to you Dr. Mary Ackenbom. I should tell you that you're getting to see a lecture that we at the ADRC were privileged to have from Dr. Ackenbom not too long ago. We liked it so much that we thought she would be great to bring to you here today. Dr. Ackenbom is currently an assistant professor in the Division of Urogynecology and Pelvic Reconstructive Surgery, which is part of the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of Pittsburgh Medical Center. She's also research faculty at the McGee Women's Research Institute. Dr. Ackenbom obtained her master's degree in clinical research through the Institute for Clinical Research Education at the University of Pittsburgh. She's received funding for her research from the National Institute of Health and from the Alzheimer's Association. And that funding was to study the problem of cognitive impairment that can emerge during surgery, particularly in older women, which is going to be the subject she's going to talk to you about today. Most recently, Dr. Ackenbom was selected by the University of Pittsburgh Alzheimer's Disease Center for what we are calling our Oscar Scholars Program, where she will have an opportunity to engage in leadership training with the clinical core of the University of Pittsburgh Alzheimer's Disease Research Center. So without further introduction, Dr. Ackenbom, why don't you turn on your video and go and educate us.
Thank you so much, Dr. Sweet. Thanks for the invitation from the ADRC. Thank you for the introduction. I'm really excited to be here virtually with you all today and to give this presentation. I'm just going to share my screen and then we'll get started. Are you able to see my screen?
Yes.
Perfect. Okay, so what you should know about cognitive decline after surgery. These are just a few of my disclosures, but are not really relevant for today as we're really just talking about this and really going over what I think everybody should know about this entity. So my goals for this presentation is one, to describe the different forms of perioperative neurocognitive disorders, also to examine the different risk factors for development of these disorders, and then describe the potential relationship between perioperative neurocognitive disorders and dementia. I'm also going to review some different approaches to, one, increase awareness, but also potentially decrease the impact of these disorders on surgical recovery. So just a little bit about me. So I am a urogynecologic surgeon. I'm board specialty trained in female pelvic medicine and reconstructive surgery. I take care of women who have pelvic floor disorders, and this includes pelvic organ prolapse, urinary incontinence, fecal incontinence, pelvic pain, amongst many others, but those are sort of the big four. I had found in my practice that there were patients and families that were returning to me in the post-operative period and sharing that they were doing well from a major surgical recovery standpoint, meaning they're checking all the boxes, right? Their pain is resolved, they're not having any issues with bladder emptying, their wound appears healed, but they're now having this issue with some fogginess or some memory loss. And I found those cases to really stay with me and found them to be quite striking, which led me to wanting to investigate this more. And so why is this important in urogynecologic patients? Well, often my patients are older and they have a tendency to sometimes be more frail. And that can put women at risk of cognitive decline and impaired functionality after surgery. Also, a lot of the surgeries that I perform are quality of life based. These are not emergent conditions that require urgent surgery. A lot of times we're able to really sit down and talk about the risks and the benefits of surgery. And there are also some treatment options that are non-surgical in nature. So it's really important to be thinking about, I can fix your quality of life issue as it relates to your pelvic floor, but I don't want to exchange it for now having a cognitive decline or a cognitive impairment. The other thing is, just in medicine in general and with surgery in general, the hospitalizations after surgery are getting shorter and shorter with a lot of the enhanced recovery after surgery programs that we have in place, which is fantastic for patients. But it also decreases the potential for recognizing there being a cognitive issue after surgery. So POCD, which is, I'll talk about that a little bit more, but any cognitive decline after surgery, as an outcome, we really need to be thinking about how this may impact somebody. And also it may influence whether a person decides they want to move forward with surgery or if they don't want to move forward with surgery, or how they make a plan as to, they're going to undergo surgery, then recover from it, right? It's part of the shared decision-making process. So I have a question for you all. In-person lectures are nice because I can see the audience and I can see people shaking their head yes or no. Virtually, this is a little bit more challenging, but I'd like to know if you could just pop it into the chat, do you know somebody who's experienced any new cognitive decline or cognitive impairment after having surgery? This could be a family member, a friend, it could be somebody you've cared for in the past. It could be anecdotal. If it's something you've seen, you can send me a yes or a why. If this is not something you've seen and you're like, no, I want to hear more about this, put a no in the chat, anything to just give me a sense of what you guys have all sort of experienced and heard about. While you guys are popping that in the chat for me, I'm just going to sort of present a patient of mine who I will, of course, protect their identity, but a case that, I took care of. This was a 76-year-old woman coming to see me, elected to undergo gynecologic surgery for her pelvic organ prolapse. She had a vaginal hysterectomy with a prolapse repair. It was extensive. It was done all vaginally, nothing abdominally, right? So no incisions that we had to worry about on her abdomen. But the procedure is about 3 hours. Her history was largely unremarkable. She's pretty healthy, just had some high blood pressure issues, a little bit of reflux, and had some arthritis. Her only other surgical history was that she had a right knee replacement a couple of years prior, but she was very much functionally independent. She was, taking care of herself, doing all of her grocery shopping, doing all her driving. She was completely independent. Lived alone, but daughter lived nearby. At her first follow-up, and I usually follow up with patients about a month after the surgery, overall doing well in terms of the sort of major milestones that I look for, which again is pain, bowel and bladder functioning, and then of course how they're healing from a wound standpoint. She didn't mention any issues with cognitive concerns at that time. But when she came back 12 weeks after her surgery and her daughter came with her, that was the time when they had shared with me, the daughter said, mom's just not quite the same anymore. She shared with me that she felt like she was just in this fog and she was hoping that it would get better, but it just didn't seem to go away all the way. A lot of just like trouble with remembering names of things, trouble with remembering activities that she was planning to do, losing things. And so that's just one example of a number of patients that have come back and sort of shared with me that they were having cognitive issues afterwards. And I can see in the chat, thank you for responding to this. There's quite a few yeses, and there's definitely some no's too. So I'm happy to chat with you guys about this more. Okay, so let's talk about perioperative neurocognitive disorders. This is an umbrella term, and I say that to mean that it's sort of all-encompassing of any sort of cognitive decline or impairment that happens as it relates to surgery, right? It's happening after surgery. And I like this picture here, because it sort of shows you like a timeline. You can see this arrow at the bottom, sorting over time. There's delirium that we worry about initially, but then later, as we get out weeks to months, we start thinking about postoperative cognitive dysfunction. Let's talk about delirium first. So delirium is an acute confusional state. It's characterized by some inattention, so inability to focus. There may be some varying or different levels of consciousness. You're disorganized, but more than anything, it's fluctuating in nature, right? It waxes and wanes in terms of how you're thinking and your mentation after surgery. The research and studies that have been done have reported a huge range in terms of how often this is happening. 3 to 70% is huge. But it really does depend on the type of surgery that's being performed, the length of the surgery, and then also who's being studied, right? Who are the patients that are in these studies? Often, or most often, delirium, when it occurs, is within the first 3 days after surgery, and then it tends to resolve. And there are a few different forms. There's the hyperactive form that often people think about when they hear about someone being delirious. That's when it's like, oh, they have an IV, there's a tube there, they think it's a snake, they're pulling it out of their arm, or they're pulling out a Foley catheter. But there's also hypoactive forms where the person who is in a delirious state is actually, everything's moving much slower, right? There's sort of what we call psychomotor retardation. They're talking slower, they're moving slower, everything is sort of slowed. So it can be two of those forms. And as you can imagine, the hyperactive form is probably a lot easier to pick up on. A hypoactive form, maybe not so much, right? Because it may be presumed, oh, the person might just be tired. And so that means it could be missed. And then, of course, there's mixed forms of this as well. So what are the different contributors to postoperative delirium? We're going to go around this wheel, just the things to think about that may predispose one to developing it. So older age, sensory deprivation. So that's like, is there an issue with hearing or vision? And that's not optimized for them. Any functional impairment, is the person not independent or dependent in some way for some, part of the activities that they do to maintain their daily routine? Is there any underlying pre-existing cognitive impairment? Is the surgery going to be longer in duration? And then, of course, if the person has any comorbidity, so multiple medical issues may greatly contribute to the potential for developing delirium as well. So if one becomes delirious and has postoperative delirium, well, what does that mean, right? It has the potential to, be associated with a prolonged length of stay in the hospital. It may be that that person who's been delirious ends up having a decreased functional independence, meaning that they're not any longer able to take care of themselves, maybe not able to cook or bathe or do the maintenance that they need to, paying bills and whatnot at home. But they're at greater risk of dementia. There's a caregiver burden that can be huge in these cases as well. And then, of course, there's increased healthcare costs and the potential for increased morbidity and mortality with more complications in the postoperative period. So I pulled this slide up just because I want you all to see, there's been a good amount of work done on postoperative delirium and delirium in general. And so there are many different tools out there that are available to be able to diagnose and to assess or screen for postoperative delirium. And I put a star next to the confusion assessment method. You can see that yellow star on the left side of the screen. And that's just one of the methods and approaches to screen that is very much what we call validated. So it's been used a lot and studied a lot and is known to actually capture delirium. And the other thing I wanted to bring your attention to is if you look at this table and you look at the third column, it says ratings done by. And so you can see it's a myriad of different types of people who are doing these assessments. It doesn't need to be a physician. There's nurses, there's other clinicians, there's research assistants, there's people who are just trained interviewers, right? And so that means that potentially everybody can sort of know what to look for in order to be aware of the potential for delirium. Now, this is a study that was done by Mark Antonio and his team that looked at identifying a prediction rule for evaluating for delirium after elective non-cardiac surgery. And so what I mean by that is this is not surgery on the heart, and it's surgery that is done not in an emergent manner. And I don't want to get in the weeds about the study itself. I just want to highlight a few things and the take-home point that I would want you to take from this research. So they did this, and they were able to sort of dichotomize or group out the patients who were enrolled in this study by the surgery type that they had. And so you can see in the purple box up at the left upper corner, those were patients who had aortic aneurysm surgery. Now, your aortic aneurysms, so that's a major artery coming from your heart, and then sometimes there can be ballooning out of the wall of that artery that requires repair. So as you can imagine, close proximity to the heart, there may be issues with oxygenation, et cetera. It's a longer surgery. The incidence of delirium in that type of a surgery was 41%, right? It's pretty high. But some might say, well, my surgery that I'm getting is a small surgery, right? That maybe it's not as big of a deal if it's a little bit further away from the heart, further away from the brain. So you can see in the yellow box, this is non-cardiac thoracic surgery, still some proximity to the heart, but more related to the lungs. And that incidence of delirium was 14%. As we start getting further and further away, vascular surgery had an incidence of delirium of 10%. Abdominal surgery, and that was really with general surgery. So we're talking about like gallbladder removals or colon removals. That was 5%. And then with orthopedic surgery, that was 9%. So we're talking about knee replacements, we're talking about hip replacements or hip surgery for fractures, things like that. So although the other non-aortic aneurysm surgeries are not as high, it's still happening, right? It's still happening in these elective surgeries that are more distal from the brain and from the heart. And that's the take-home point that I want you to get, is that we're seeing this delirium in these patients who are undergoing these types of surgeries, which are quite commonplace. So now let's sort of go down the timeline a little bit further, postoperative cognitive dysfunction. So this is a bit different. This is an impairment of memory, concentration, and information processing speed. It's different from delirium and dementia. It's its own distinct entity. It typically lasts weeks to months. However, in the past, there have been reports of cognitive impairment that last for years. So with POCD after major elective non-cardiac surgery, so the similar types of surgeries that I've been describing, the incidence of this ranges between 7 and 41%. It's thought to be associated with ultimately having loss of independence. Again, one not being able to care for themselves and do the activities of daily living that they were once doing prior to surgery. Patients reporting a decreased quality of life. And then again, increased healthcare costs and increased morbidity and mortality. Now, what's really significant about postoperative cognitive dysfunction or POCD is that this requires neurocognitive testing in order to diagnose it. And neurocognitive testing is formal. This is not the type of screening test that you can go at the bedside and do it in just a few minutes. This is something that requires some training and some time. And because we don't really use these types of tests in a clinical setting, is really hard to ascertain or know what the incidence really is. And so it's often underestimated, right? And this is also in the setting of patients undergoing these surgeries and potentially going home sooner, right, as what's changing in medicine. So POCD, even though we're capturing it in research studies up to 40% of patients, this may be an underestimation. What is required for POCD diagnosis? We're looking for a decline on these formal cognitive tests. And usually we're looking to see what's happening prior to surgery and then after surgery. It also can be done where you're looking at patients in the post-operative setting, and then you look at data of cognitive tests that have been done in patients who have not had surgery, right? So we call this normative values. We want to know how these tests look or perform in patients who are just normal at their baseline. So you can compare it to that. There has not been any agreement amongst researchers and clinicians in terms of what criteria we need to use in order to meet the diagnosis of POCD. And that is quite problematic because researchers and clinicians are doing this work, which is great, but we're all using sort of different thresholds. And so it's very hard to interpret what these results mean. And so it's ideal, as we move forward, to try to get us all on the same page, have the same criteria in place so we know how to interpret our findings. So what has been done? One of the largest studies that has been done is this, I call it IS POCD1 study. And this is an international study of postoperative cognitive dysfunction. It was a multi-center study, and it basically involved, patients and people, not only in the United States, but in European countries as well. So it was international, and that was great. And they enrolled people who were older than 60 and scheduled for, major non-cardiac elective surgeries undergoing general anesthesia. And with this, they were testing, people were doing that formal testing before the surgery, and then they did it 1 week after surgery, as well as 3 months after surgery. And again, I don't want to get into the weeds of this. I want to highlight what I think is important for you to know. So they had 1,200 people in this study. And what they found was that at 1 week, there were people who had significant declines on their neurocognitive tests at an incidence of 26%. So 26 out of 100 people were having cognitive decline issues after their surgery. And then looking at this again, 3 months later, it was about 10%. So 10 out of 100, still 3 months later, are having cognitive decline issues. So for me, I saw that, I was like, wow, this is striking. And then I was seeing this entity in my practice that I was seeing clinically. And so that sort of stemmed us when we started first looking at POCD and a cohort of patients undergoing prolapse surgery. And so we were similar in that we enrolled women here in the Pittsburgh area who are scheduled to undergo major prolapse surgery with one of the 6 attendings here at UPMC. And we were very strict in how we defined POCD. We were looking for either mild declines of cognitive function on multiple tests, or what we would call major declines on at least one test. And we were interested at the 2-week time point. 1 week is pretty soon after surgery. Some may argue that there could be some anesthesia effect at that point. But 2 weeks, we felt like, most people ideally want to be back to their baseline. Most family members, if they're coming into town to help, mom recover, they're gone by this point. People are thinking about driving, if not already driving at this point. So we wanted to get a sense of what might be happening at the 2-week mark after surgery. And this table, I don't want you to get lost in. What I want you to pick up is that, one, the blue box on your right shows that there was an incidence of about 33%. So 24 of these women out of the 72 who had pre and post-operative testing had impressive and significant cognitive decline on their neurocognitive tests. What this figure should show you, 1 dot in each of these boxes would represent like a mild decline, and 2 represents more of a major decline. And I must tell you, I was struck by the amount of double dots that I was seeing for these patients. So this is real and it's happening. Now, what has been great is that, the International Society to Advance Alzheimer's Research and Treatment has a nomenclature consensus working group. And they've been working together. They recognize the issue of all this, what I call heterogeneity. Everybody's on a different page in terms of studying perioperative neurocognitive disorders. And because of that, it's really hard to interpret the data and ultimately it limits us in how we can take care of our patients. And so they came together and made this plan of, this is our recommendations of how we are going to define and how we are going to word these entities. What should stand out for you on this table 1 is that they are calling up to 30 days after surgery, they're calling this delayed neurocognitive recovery. This is important because a lot of POCD research has looked at, you saw one large study at 1 week, I chose 2 weeks as I thought that was clinically relevant. But now we can all be on the same page and say, okay, if it's within 30 days, we're not really calling that POCD at this point, but we are calling it delayed neurocognitive recovery, and we do think that that should be significant. And researchers everywhere are starting to integrate this nomenclature, which is great. The other thing to note is, so with post-operative delirium, they made sure to give sort of a time frame. So they're saying that this is up to a week after surgery. And then after that, if there's, if they're seeing this sort of, fluctuation in mentation and entity, then we need to start thinking about other potential diagnoses, namely, is it delayed neurocognitive recovery? And then, of course, they made sure to note that, providers and researchers should be thinking about the vulnerabilities or potential drug effects or physiologic changes that may be contributing to delirium as well. In regards to POCD, some of the recommendations that I think have been great to note is that they really wanted to align defining the definition for POCD with what has already been done. So there's the Diagnostic and Statistical Manual of Mental Disorders, something from the American Psychiatric Association that sort of gives us an overview of all the different sort of mentally related diagnoses. And mild and major neurocognitive disorder is included in this book, in this document. So they recommend aligning the criteria that we use for POCD along with mild and major neurocognitive disorders. And that's great, right? Because it means we all can be on the same page again. The other thing is that they do recommend the use of normed data. I talked about this in terms of how patients or non-patients perform on a neurocognitive test and how that compares to patients. Or controls, but that needs to be used if there's no way to assess for any change, as opposed to just assuming what that change may be. And then the other thing that was really important that stood out from these new recommendations is that they didn't really specify how many tests needed to be used, what part of cognition and how one thinks needs to be evaluated, but they did say that it does need to be formal neurocognitive tests still. And it can't be a screening tool. There's some screening tools that we use for cognition in the clinical setting. Some of you may have heard of the mini mental status exam or the MOCA, but that's not something that really can be used to assess POCD. It needs to be that formal cognitive testing to really ascertain what changes are happening with cognition. The other thing that stood out was that they noted 12 months as the time point where post-operative as a specifier is no longer attached. So if there's cognitive change that's happening after this mark, it needs to be we need to be thinking about other potential diagnoses. I like this figure because it illustrates sort of a concept of what might happen with cognition after surgery. So the lettered lines on the right you can see. Line B is supposed to represent somebody who's not had surgery. This is supposed to be steady for the most part, maybe a slight decrease, over time. Time is that bottom line that you can see. But then you can see C, D, and E. These are potential changes that may happen with POCD and that somebody may rebound and possibly almost all the way recover. But then, D and E, these are potentially people who are not able to recover at all. So what are the risk factors for perioperative neurocognitive disorders? I mentioned a few of these, but I like this table here because it puts it side by side, some of the major factors to think about. And the ones that are really, factors for both post-op delirium and POCD include older age, the type of surgery the patient underwent, poor functional status at baseline, and then any pre-existing cognitive impairment. This figure here also represents, other factors that may contribute to the development of POCD. I always tell my patients when I'm talking to them about the potential for cognitive decline after surgery, and that it's multifactorial. There's so many things that we have to consider because you are undergoing a surgical experience that's going to include both anesthesia and the surgery that I do itself, and what you come in with and bring to the table. So you can see in the middle of this figure here, it talks about mean arterial pressure. So what's your blood pressure? How's your oxygen? What's your blood count? And then if we go around, you can see on the right side the anesthetic doses. What anesthesia medications are they receiving? How's your oxygen level during the procedure? There's brain level changes. There's the blood-brain barrier. We're going to talk a little bit more about that. Vascular mechanisms, are there little blood clots that may be contributing to why you're not getting as good of blood flow? And then, of course, there's inflammation to consider as well. So I like this figure here because it allows us to talk about the surgery and how the surgery itself may impact the brain. So when I talk to my trainees, I talk to them about inflammation and what that really means. And an inflammatory response is the body's sort of way to respond to some sort of irritant. Now that irritation could be in the form of a germ, like a bacteria or a virus. But it could also be in the form of like a chemical or radiation. But then also it could be in the form of trauma, right? Like you think of a splinter or something bigger like a surgery. A surgery is a controlled trauma. And so, if we think about surgery, look at the left side of the screen and you can see this pink box, it says periphery, right? That's what's going on, in your extremities and externally, away from your central nervous system, away from your heart. So there's this inflammatory stimulus, that's the controlled trauma of surgery. And ultimately, there are some substances that are released as a result of you damaging or injuring tissue in order to achieve the goal of the surgery. And that leads to some systemic inflammation. Those inflammatory mediators or those substances that are released by the surrounding tissue go into your bloodstream. And then as it is in your bloodstream, it's circulating throughout the body, right? And then it has the potential to encounter the brain. And then that's when it meets the blood-brain barrier. I like to think of the blood-brain barrier kind of like a gate. And I think everybody's gate, or their blood-brain barrier is a little bit different. There's barriers that are sort of like a wooden plank fence where it's not a whole lot of spaces to get through. And then there's iron rod gates that are there, but lots of space and lots of potential movement. And so that speaks to the nature of how permeable a blood-brain barrier can be. So briefly, I want to talk about, the blood-brain barrier permeability can vary simply based on some of these factors I list here: older age, trauma, stress. There could be comorbidities underlying like diabetes, hypertension, Alzheimer's, dementia, as well as some other neurologic disorders. And then, of course, medications can change the permeability too. And so back to our picture on the right side of the screen now, right? So blood-brain barrier, it's weakened. And then they're, depending on what mediators get in, they can impact the cells that are in the nervous system and then ultimately lead to neuroinflammation. You see that purple arrow, and then ultimately that cascades down into there being some neurologic dysfunction of those cells, and perioperative neurocognitive disorders can occur. So the surgery itself can have a role. It's not just the anesthesia. And then you can imagine even further how all of these different factors can sort of integrate and play off one another, and people can have more of an issue than others. So let's talk a little bit about anesthesia, and POCD and dementia. So the relationship between surgery, anesthesia, and dementia is really unclear. There have been, a few studies done that have, commented on it and looking at things long term. But there's been some issues with many of these studies and some limitations that sort of limit how we interpret the findings of it. I'll tell you, so there was a large review where they combined 15 studies together to say, okay, if we put all of this data together and we really look, was there any association between the use of general anesthesia and the development of dementia? And then in that review, they did not find an association. There was also a very large study of 4,000 patients in which they were following these patients, and they found that there was no increased risk of dementia in those who had undergone anesthesia as well. However, there are other studies that have been done that have, noted that there is an increased risk. There was a large case control study of over 135,000 records that they had that they were able to look at, and they found that there was an increased risk of dementia in those patients who received anesthesia. And then there's the Optima study, and this was of about 400 patients, and they looked at those who underwent major surgery and found that those who had a pre-existing cognitive impairment ended up having worsening function as it relates to cognition. So I can tell you that most of the work that's been done and what we have found is that if perioperative neurocognitive disorders occur, it tends to seem like it resolved by a year. But there are those cases where it persists beyond that. But then are we talking about a perioperative neurocognitive disorder, or is there a transition to some sort of mild cognitive impairment or dementia? I want to just touch on this Optima study really quick, just because I think the figure is quite nice and you can see. So looking at the blue, these are participants or patients who have no pre-existing cognitive impairment issue at all. And then the orange are patients who have some sort of cognitive impairment issue at baseline before they undergo surgery. They looked at patients in these two cohorts of groups. Those who had a solid line had surgery. Those who had a dotted line did not have surgery. You can see with the blue, not so much, over time is this bottom horizontal line. You can see there's some sort of subtle decline, but not major differences between that solid surgery line and that dotted non-surgery line in the blue. But for the patients with pre-existing cognitive impairment, and this is in the orange, you can see that solid surgery line takes a major drop. It's definitely different than that dotted line of patients who do not or did not have surgery. And so that just speaks to the nature of, pre-existing cognitive impairment really may be a major risk factor for how these patients do in the postoperative setting. So how do we increase awareness and decrease the impact of perioperative neurocognitive disorders after surgery? This figure or this picture I like. This is a list. It's a perioperative assessment that was put together by the American College of Surgeons as well as the American Geriatric Society. And what they have done is essentially sort of highlighted the things that are important to sort of incorporate and think about as you are getting patients and people ready for surgery. I put 2 stars by the ones that I think are really, really important. So there's a yellow star next to, assess the patient's cognitive ability and capacity to understand the anticipated surgery. One, this is important so we know their baseline, right? We need to know where they're coming from, what's the starting point. But 2, also, it's really important, as a surgeon and as a person taking care of these patients, we want to make sure that the patient understands what they are about to undergo and all the potential risks and benefits and alternatives that are available to them. And I think that's all encompassed here in that first yellow star. And then second, the second yellow star down at the bottom is to determine the patient's family and social support system. And this is really important as well. Patients are going home shortly after surgery. I didn't mention, but I said shorter hospitalizations. I'll tell you, with urogynecologic surgery, although these surgeries can last 3 to 4 hours, 90% of our patients are going home the same day. And I think this is starting to become more commonplace with many elective surgeries and surgeries in general after surgery. And so it's important that patients are surrounded by people who, one, can help them get the things that they need while they're in recovery, and 2, recognize if something's not quite right. The patient is busy recovering her or himself. And so having somebody there who may recognize if something is a little bit off is an opportunity to alert other physicians and providers so that they can engage and help the patient to not have any other major sequelae or problems and complications after surgery. Other things to consider, I think is important. Cognitive decline after surgery is an important consideration for all surgical specialties. A lot of the early work was focused on cardiac surgery and brain surgery because the thought was, oh, well, that's impacting the amount of oxygen getting to the brain. Those patients are having these outcomes more often. But really, this is happening after any surgery. This is happening after all of them. It needs to at least be a discussion, and it needs to be a consideration. And I do think that, with this release of the nomenclature recommendations, it's already been integrated into many researchers, protocols and how they're assessing for POCD and postoperative delirium moving forward, which is great. And, we'll be able to see and hopefully be able to pull some of the data that's coming out in studies that are ongoing now. So pearls and take-home points that I want you to have. One, so there's still a lot of unanswered questions about perioperative neurocognitive disorders. I would say if you have to have sort of like a number or a time frame in mind, generally the findings from research suggest that if there are changes to cognition and memory after surgery, They resolve with time and most likely resolve by a year, but we don't understand this very well. And the link to dementia is not well understood either, and more work really does need to be done. I encourage all of you, if you are thinking about surgery or planning to have surgery, talk to your doctor about this potential outcome, any cognitive decline after surgery, so that you guys can talk about it. Your physician may be able to determine or consider putting together an interdisciplinary team. I know I often do. I will engage a geriatrician, I will engage anesthesiology, and we'll come together and make decisions about what we should do preoperatively, postoperatively, in order to minimize this outcome. And then, as I mentioned before, just having an in-person support system, I think, is really key during the first week after surgery, especially. I know for my patients, my older patients, I ask them to make sure that they have somebody who's actually in the house with them, especially for my patients who live alone for at least 1 week after surgery. I think that's really critical and important. So thank you so much again for the invitation. I welcome your comments and questions, and I'm looking forward to a discussion. Thank you.
So let me at least start by saying thanks for a great talk, Mary, as always. Appreciate it. Everyone, please do your best to type your questions in. You have the wonderful advantage of having Dr. Ackenbom, who has so much practical experience here handling stuff. So can help you out with any of the, hopefully can address the issues you may have.
Hi, I'm Mary Ann Oakley. I'm going to be assisting in the questions today for Dr. Ackenbom. Dr. Ackenbom, there's one question that popped up asking if there are different types of anesthesia that can be used as a consideration for someone who maybe has some risk factors. Is that something that can be requested from the anesthesiologist?
Absolutely. So, when I think about surgery, particularly the surgeries that I do, but really, you'll ask your surgeon about this. There's general anesthesia, and this is when you essentially are paralyzed and then a machine is used to breathe for you while you're undergoing surgery. And that can be really important depending on the type of surgery. There's regional anesthesia, where there are medications that are used to block large nerves. So that way you are comfortable, but not necessarily paralyzed and having a machine breathe for you. There's also local anesthesia, right? This is like when you go to the dentist and get a tooth pulled, you can use larger amounts of that and have local anesthesia. And usually if there's regional anesthesia and local anesthesia, you're getting some sort of sedation like twilight sleeping medicine so that you're not aware of what's happening. The research that's been done has been somewhat mixed on this. So there have been some studies that have compared general anesthesia to regional anesthesia and seeing if there's differences in outcomes of perioperative neurocognitive disorders. And in the long term, it seems like there is not a major difference, but in the short term, it seems like there is. And so often we find that we do recommend, or at least consider and think about regional anesthesia for patients who may be at higher risk of any cognitive complications afterwards. That is a discussion because, depending on the type of surgery you have, sometimes that regional anesthesia has a time limit. And so if your anticipated surgery is going to be longer than the time that you would be able to get anesthesia and, coverage of your pain, it may not be a good option for you. But absolutely, it's a consideration that I have for many of my patients. I'm always thinking about ways that we can sort of minimize the anesthesia that we're putting on board.
And I think it's important for people, particularly people that are attending this talk, to know that they do have the option to bring that up and discuss it. I just think of myself in an instance when nobody really asked me about it and you're going in for surgery and this is what they're doing. So it really should be a discussion that everyone has.
Absolutely. And I've often, I can think of some cases, of women who have said to me, they've expressed, that they've delayed their surgery for years because they're scared of the anesthesia and they're concerned about it because of the risk of cognition issues afterwards. And so that may be an opportunity for an anesthesia consult. There are many, anesthesia programs and doctors that will meet with patients beforehand and really take into account all of their medical comorbidities and their history to figure out, is general anesthesia the safest thing to do, or can we do regional anesthesia while keeping the patient safe and achieving the goals of the surgery as well?
That's great advice. Here's another question. When comparing groups of individuals who do and do not receive surgery, how do researchers account for the fact that individuals in the surgery group have an underlying acute condition that requires surgery in addition to the anesthesia from surgery?
So just I want to make sure I clarify the question. So you're asking, how do we account for an acute condition, meaning like, is there an emergent issue? Like, are we saying surgery for emergency, or like a comorbidity, like a underlying medical condition?
I'm not sure what the person is asking, so let's see if they can clarify.
And I'll look for that too, if they clarify. I will say that, with a lot of I think that's part of the issue with the research that's been done, is that we're trying to make these cohorts or groups of patients who've undergone surgery, but it's really hard if you have different indications for it, right? Like, I do prolapse surgery, but some of those women are predisposed to recurrent bladder infections. And sometimes those bladder infections can turn into kidney infections. And if they have a kidney infection, they already have some form of systemic inflammation, and that might impact their brain, right? Depending on their blood-brain barrier and the status of that. So you're right in that it's hard to, we have to think about controlling for all of those different factors. I think it really does make it challenging in studying this in research, because there's so many potential, things that can contribute to the development of POCD. And ideally in research, we like to control for as many things as possible. And it's really hard to do that with this particular entity. And so I think with some studies, they can try and do with some stratified groups, meaning that they sort of cluster certain groups of people together that may not have these sort of outlier conditions or have these underlying indications for surgery. But it's a major limitation and something that researchers have to think about when they're strategizing their methodology and studying this.
Okay, thank you. Someone asked, what are the topics that you would discuss with the anesthesiologist prior to a surgery? So if someone had to go in with a checklist, maybe they're looking for some suggestions of what they should put on that checklist.
Sure. So in regards to, as a surgeon, I usually try to explain what I think the plan will be for surgery and what the surgical options are in regards to anesthesia. So if that means, yes, we're going to plan for an abdominal approach to fixing your prolapse, I'm going to do this laparoscopically, that requires general anesthesia. I usually give a general explanation of that, just like I said before, where your body will be paralyzed and they'll have a team there that's helping you breathe on a machine. And so there will be a tube down your throat that's sort of doing that for you. And explain that you'll get medications through the IV to keep you, comfortable, and we're monitoring vital signs the whole time as well. If they have more questions about the anesthesia and the anesthesia process than that, I do think that it's important to go ahead and refer them for an anesthesia consult so that they can talk about that in detail. And the questions that they should ask about is, one, like, how long are you expecting me to be under anesthesia? What can I expect, post-operatively, especially if you've ever had issues and you've had surgery before with like nausea or pain control? I would ask those things up front as well, because some of those medications that they will give you to help with those symptoms might actually also contribute to potential development of delirium and cognitive impairment too. So asking them about what to expect in terms of the time frame, what that experience is, if it's regional anesthesia, that means that you may be getting an injection in the back or in the joint. What to expect in terms of how you'll feel, from a post-operative setting. How long will this anesthesia and potential fogginess last? Could be days, right? And so you want them to talk about that as well when you're talking to them.
Okay. Thank you. Here's another Another question. My mother was given anesthesia during hip replacement surgery in 2008 and 18 that she did not wake up from for a full day. She experienced serious delirium. The doctors had her take a CAT scan and felt that she had a clot break up and travel to her brain during the surgery that caused tiny ruptures in the vessels in the brain. She was 93. And then at 94, she needed a vascular surgery and woke up with no problem and no delirium. Was that an issue with the type of anesthesia that will be used? She will be 96 next month and with some cognitive decline that I think is not connected to her surgery. Do you agree?
So first I would say, I'm sorry that she had that experience. I'm sure that was probably quite scary for you in seeing that. It is interesting that she had that experience with the one surgery, and then the surgery later, when she's older, she didn't have an issue at all. But I also think that sort of speaks to the nature of how it's so multifactorial. She was getting a hip replacement. I would think about and at least consider and ask, was she having any major issues with the hip? Maybe there was already some inflammation that was going on at baseline. There could be other, reasons that other medications she was taking, other things that may have impacted the state of her brain. If they thought that something broke off, like a clot broke off and traveled to her brain at the time of the surgery, that's not, that's related to the surgery in itself, right? That's not something that, it's definitely something that we consider as a possible complication, but not something that's necessarily related to all surgeries. Something that we think about with joint surgeries a little bit more. So being that it sounds like she's overall doing great and has had some cognitive decline, I think maybe, that figure I showed before where it was sort of like what trajectories or what do people look like over time, she may have been somebody that was like that, the C line, right? Somebody who may have had a dip down, but was able to recover, but still is having a little bit of decline as you would see with age. And so that's great for her that she's doing well and doing good overall. I think that's pretty good. I think that maybe she, from that first surgery, it sounds like she definitely had, an issue with cognitive impairment post-operatively, but doing well overall now.
Right, good to hear that. One more question. In cases where they've used general anesthesia along with a nerve block, is there an increased risk of developing POCD?
So, that first I will say that the research on that specifically has not been done, and where they're looking at the combination of regional and general. I'm trying to think of circumstances when you would definitely use regional and general intentionally at the same time. Often you will see somebody who's, if they get both, they've started with regional and had to convert for some reason. And so that in itself can sort of bring in another element of, potentially increasing that risk. So there's no, good, strong data out there of, researchers that have studied this where you get both types of anesthesia and that increases your risk. But absolutely, I mean, you've got more meds that you're being administered. So there's always the potential for that. And then the underlying reason of needing both also may be a contributor as to why one may experience cognitive decline at a greater incidence.
Okay, I definitely agree with that. We're getting close to the end of our hour. I'm going to ask if anyone has any final questions. We can probably take one more. If not, we can perhaps get Melita back on to thank the speaker, thank all the attendees, and wrap up our presentation for the day. So, final call for a question. We've had a couple of really good questions.
Yeah, these have been great.
All right, I don't see any other questions popping up. So Melita, let's hand it back over to you.
Thank you, Marianne, and thank you, Dr. Ackenbom. Can everyone see me? Wonderful. Thank you so much, Dr. Ackenbom, for such an interesting and informative topic for us to learn and listen too. We greatly appreciate you sharing your expertise and most importantly, your time with us and the community today. We will be sending out an email with the survey link to evaluate today's event. So please keep your eye open for that. We greatly would love your feedback on today's session. Thank you again, everyone, and have a wonderful day.